Hello, you are listening to the RxConnect podcast. This podcast is brought to you by the pharmacy operations at the American Oncology Network. We are committed to delivering operational, clinical, and financial efficiencies based on the most sustainable model, reshaping the future of community oncology practice. I am your host, Melody Chang, Vice President of Pharmacy Operations at the American Oncology Network. Today, we have a very special episode focusing on some of the most significant lung cancer trials presented at ASCO 2024. I am delighted to introduce our outstanding guest speaker, Dr. Rangappa Rajendra. Dr. Rajendra has been practicing medical oncology and hematology in Loudoun County since 1991. He attended St. John's Medical College in Bangalore, India. After completing his internal medicine training at Grand Hospital in Chicago, Illinois, he then completed his fellowship in medical oncology and hematology at Washington Hospital Center in Washington, D.C. During his training, he conducted research on breast cancer, ovarian cancer, and lung cancer. Dr. Rajendra is board certified in internal medicine and medical oncology. He founded Oncology Hematology of London and Reston in 1997. Welcome, Dr. Rajendra.
Thank you very much, Melody. And thank you very much for the rest of the group staying and working with me today.
Thank you. So, Dr. Rajendra, before we get into the specific trials talking at ASCO this year, could you please educate our audience on lung cancer in general? And can you give an overview from diagnosis to treatment and the survival outcomes, please?
Yeah. Just like any other cancer, it starts with the diagnosis. And this day and age, probably there are two important ways we get the diagnosis. One is by bronchoscopy, where we go to the pulmonologist. And this day and age, there are many different ways of getting the biopsy. And the newest techniques which they use is the so-called navigational bronchoscopy, which can reach very close, even further down the main bronchi. And the second way we get the diagnosis most of the time is by using the intervention radiologists. So they do get the biopsy either from the lung, from the lymph nodes, or one of the tissues which has a metastatic site. So this is the cornerstone for diagnosis. Once we get the diagnosis, the pathology is forwarded to the pathologist. And there's one comment I have to make about the pathology. You always have to tell the pulmonologist or the radiologist to make sure they need to get adequate tissue sample. This is very, very important. Pathologists need only a very, very small sample to give the diagnosis. But this day and age, if you want to manage a patient, you need to have a lot more tissue to do the next generation sequencing studies. Unfortunately, more often, you get a very small sample and you get the diagnosis, but then you don't have the NGS studies to back you up. So generally speaking, what I do is whenever I have a diagnosis of lung cancer, simultaneously, I do the circulating tumor DNA and then wait for the next generation sequencing studies from the tissue sample to come. The circulating cell-free DNA takes probably about maybe 10 to 14 days. It comes on very fast. And then the tissue-based one, depending on the lab, it may take anywhere from 4 to 6 weeks. One thing I want to mention to you about these studies is the these studies are very, very specific.
Mhm.
Where the lack is the sensitivity, especially the circulating tumor DNA.
Right.
Sometimes in circulating tumor DNA, you find everything, not just related to the tumor. If
Mhm.
somebody has some hematological issues,
Uh-huh.
you may get what we call as a chip mutations from the bone marrow, KRAS mutations.
Uh-huh.
And sometimes if somebody has a BRCA mutation or one of those germline mutation, that can also be found.
Mhm.
So you have to be very careful to tease out those things and look for the one which is related to the tissue.
Right.
So once you get this information,
Mhm.
one other thing I want to mention to you is I know some oncologists are still hesitant to do the next generation sequencing studies. They say they
Right.
want to wait. What I
Mhm.
want to emphasize is today, it doesn't matter what stage they are without
Mhm.
knowing the exact stage. I strongly urge everyone to start doing the next generation sequencing studies as soon as possible. As
Right.
you know, that today we're using next generation sequencing studies even as adjuvant treatment, which
Right.
means where we treat patients anywhere from stage 1B to 3B,
Mhm.
where we definitely want to know the EGFR mutation, ALK mutation, the PDL1 status. And
Right.
now, of course, in stage 4, we've already been treating that.
Mhm.
So it's a must, it's imperative that we need to really get the next generation sequencing studies as soon as possible.
Mhm.
Now, a little bit about the, um, just to give you a perspective about the prognosis,
Right.
I'm going to quote the surveillance epidemiology and end result survey, so-called SEER data,
Mhm.
which the National Cancer Institute, American Cancer Society use.
Right.
So from 2012 to 2018, non-small cell lung cancer, they usually classify that into three categories.
Mhm.
They call it as a localized,
Mhm.
regional, or
Mhm.
distant. In the
Right.
localized means it's confined only to the lung. In
Mhm.
the regional, it goes to the hilar and the mediastinal lymph nodes in the chest.
Mhm.
Distant means, it's gone outside the lung to other organs or structures.
Mhm. Mhm.
So, in practical terms, if I want to go back to the usual staging system, the AJCC or the TNM,
Mhm.
the so-called localized cancers are stage 1A1,
Mhm.
2A2, A3, 1B, and 2A. And just imagine, only about 65% of them will be alive at 5 years.
Mhm.
And once it hits the lymph nodes in the chest, it drops down to 37%. And the
Wow.
distant ones is only 9%. This is from
Wow.
2012 to 2018. So
Mhm.
this gives you an idea about what exactly the non-small cell lung cancer does.
Mhm.
Now, the other one I want to briefly mention is small cell lung cancer. Yeah,
Uh-huh.
here again, they use the same category.
Mhm.
Localized, they say 5 year survival is 30%. But I
Mhm.
want to caution you, small cell lung cancer, even if you have a small spot in the lung, it's
Mhm.
very advanced.
Right.
But of course, if you're lucky enough to find them,
Mhm.
the 5 year survival is at least 30%.
Mhm.
And once it hits the lymph node in the chest, it's
Mhm.
already 18%. When it
Wow.
becomes distant, it's already 3%. So
Wow.
this gives you a general broad idea about how the patients with lung cancer do.
Right. 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 It's very important. Yeah. Thank you so very much for this. Is
Did you want me to mention anything about the pathology about today?
I'd like you to mention about pathology as
Yeah.
well, but
So broadly speaking, we have two
Mhm.
types,
Right.
non-small cell lung cancer
Mhm.
and small cell. So in
Right.
the non-small cell, there is a mixture of many different ones. Probably the big ones are adenocarcinoma, squamous cell, large
Right.
cell adenosquamous, and then there are other more. But
Mhm.
today, most of the talk will be confined on the adenocarcinoma, and
Mhm.
the
Mhm.
so-called neuroendocrine carcinoma will be focusing on small cell lung cancer, which is the commonest lung cancer.
Right. Right. Well, this is awesome. Thank you so very much. This is a very, very comprehensive overview, and I think that gives us our audience a general idea how the lung cancer being diagnosed. And I think the early detection is important. But regarding the biomarker testing, you mentioned about the NGS testing. Is this test usually being covered by the patient's insurance?
I started using this many years ago, maybe even 10 years ago to 10 plus years ago.
Uh-huh.
I used to have a hard time trying to get the insurance companies to cover it.
Mm-hmm.
So basically now over time, what has happened is there are two things. One is what I did was to overcome that. I did meet with the labs, the so-called next generation sequencing studies folks,
Right.
and they were willing to kind of do it on all my patients, regardless of whether the insurance paid them or not.
Mm-hmm. Mm-hmm.
So that was huge for me. So I started doing it even 10 years ago.
Wow.
But now, what I can
Mm-hmm.
tell you is now it's become a standard of care. If you open the NCCN care guidelines,
Uh-huh.
they mention it,
Right.
right away. So I think now it's become like a standard of care. They cannot say that we're not going to pay a thing. So
Right.
I think insurance should be the least of the concern today.
Good, good. So the patients, regardless their stage of the diagnosis, they should all getting the NGS
Mhm.
testing,
Mhm.
right? Okay.
Yes.
Very, very good. Well, we know this year at ASCO, one of the main things is lung cancer. With the plenary sessions, we have had some strong data from a couple of trials. For example, LAURA trial, Crohn trial, and etc. What are your thoughts about those studies? Let's start with LAURA trial.
Just to give a brief introduction about the Laura trial basically focused on stage 3 patients with non-small cell lung cancer,
Mm-hmm.
which means, say, non-small cell. And then the particular subtype they focused on was adenocarcinoma.
Mm-hmm.
And if
Mm-hmm.
you break them up, about approximately 50% of them were stage 3B, and
Mm-hmm.
then maybe a third and then probably under 25% of them were stage 3A, and the other one was stage 3C.
Mm-hmm.
So the so-called stage 3B patients can constitute about 20 to 30% of all the cancers which are diagnosed, and
Right.
90% of them are unresectable, which means,
Uh-huh.
say, when you send a patient for surgery, you
Uh-huh.
cannot do a 90% or 99% surgery. They should be
Mm-hmm.
able to guarantee you 100% resection. If you
Mm-hmm.
think the patient, there are two factors which are involved. Can the surgeon do a complete resection? That's question number one.
Right.
Question number two is, can the patient withstand the major surgery? So
Right.
that's the next question. So this is very important before we pick and choose which way you're going to go. Once
Right.
you decide that, okay, fine, you know what, maybe the surgeon cannot resect it out, or the patient is medically unfit to go for surgery, which
Mm-hmm.
unfortunately are the most of the patients we see in
Right.
stage 3. Then
Uh-huh.
the standard of care today is they do get chemo along with the radiation therapy. We
Mm-hmm.
combine them together as
Mm-hmm.
much as possible. I know in some situations we have to modify that based on the patient's clinical condition to
Mm-hmm.
get the best possible response,
Mm-hmm.
and also not only the response but also the survival.
Mm-hmm.
But you're going to pay a price with toxicity when you combine both together. And
Right.
right now, once they finish that,
Mm-hmm.
we generally put them on checkpoint blockade therapy with
Uh,
durvalumab or the Imfinzi.
right.
So that's basically what we're doing for about a year or so.
Mm-hmm.
What this study did was they they followed the standard of care most of the way, chemo radiation, and then after that, they diverged from the standard of care. What they
Mm-hmm.
did was they used the next generation sequencing studies
Mm-hmm.
and pulled out the patients who had EGFR mutation.
Mm-hmm.
So those constitute about 30% of those patients who are left over with you.
Mm-hmm. Mm-hmm.
And there, what they did was on one arm, they put the patients on osimertinib or the Tagrisso. The
Mm-hmm.
other arm, they put them on a placebo.
Mm-hmm.
So basically, what they did was this is still a preliminary study. What they showed was the endpoint they wanted to look into was progression-free survival.
Mhm.
So they had probably about 260, it was a 2-to-1 ratio. So about 216 patients were had EGFR mutation. And
Uh-huh.
remember, in the EGFR mutation, they pretty much focused on the exon 19 and 21. Okay,
Uh-huh.
so those were
Right.
the common ones, not the uncommon EGFR mutations, where osimertinib has the best possible response.
Mhm.
So basically, what they showed was when they treated these patients, remember they were focusing mainly on the progression-free survival.
Right.
So they noticed that the progression-free survival at 36 months was 39.1 months with the osimertinib group, and the
Right.
placebo was 5.6. And the
Wow.
hazard ratio, which is a measure about how successful the treatment was mind-blowing, 0.16.
Wow. Mhm.
And again, the secondary endpoint was the survival. Okay, ultimately, it's nice to have a good progression-free survival, but
Right.
ultimately, when you want to hold any study, the feet to the fire, you have to look at, I put the patient on this treatment? Did the patient live longer than the patient who went on placebo?
Uh-huh.
So there, they had only about 20%. They didn't have the complete data, but
Mhm.
what they can say is at 36 months, about the hazard ratio they gave was 0.81.
Mhm.
And the ones who were on the so-called Tagrisso, the osimertinib, 84% of them were alive, whereas the placebo was 74. So these numbers, I'm sure, will hold good even down the line because
Mhm.
the benefit is so large. So I think this is something which will become the standard of care, I think. And one caveat I want to mention to you is, if
Mhm.
somebody says, why didn't they have the other arm completely the standard
Mhm.
of care arm?
Right.
Now, remember the immunotherapy or the checkpoint blockade therapy
Right.
does not work in patients with EGFR mutation. So
Correct.
we know
Right.
that very well on multiple other studies and all. So I think we were trying to find some other avenue to treat this patient. And this is huge, I think, for these patients, I think.
Well, yeah, this is amazing. Especially there's a potential this is become the standard of care for the patients has the EGFR mutation. That also emphasize again the importance of getting the biomarker testing early on, right?
Hmm. Hmm.
Yeah.
That's
Yeah.
very important. And then one other thing, people always, okay, fine, you give that. What about the um, subgroups or the safety profile and other things? So,
Uh-huh.
as you know, osimertinib does penetrate the blood-brain barrier.
Right.
There are only 8% of the patients who had brain mets on osimertinib. And I've
Mm-hmm.
seen in my own practical experience where
Mm-hmm.
we can even hold off radiation therapy if the patient does very well, or you can
Mm-hmm.
supplement radiation therapy after treatment with osimertinib. Instead of giving whole brain radiation therapy, we can
Uh-huh.
do pinpoint radiation therapy like stereotactic brain radiation therapy.
Right.
So that even there it is improved a lot. Safety profile wise, I have to say I'm very impressed with the side effects profile with the so-called Tagrisso or the osimertinib. The
Uh-huh.
main thing to watch out for is some GI side effects. Like yeah, some of the patients do have a little bit of loose bowel movements, diarrhea,
Mm-hmm. Mm-hmm.
and then of course because they just finished chemo radiation and then start with this drug. Uh, Whenever the patients get radiation therapy along with the chemo, there
Uh-huh.
is some inflammation of the lung, what we call as a radiation-induced pneumonitis. It almost
Mhm.
mimics like pneumonia, but it's
Right.
an aseptic pneumonic.
Right.
But there is a little bit increase in incidence of radiation. I'm sorry. There is little increase in incidence of pneumonitis when we put them on on the Tagrisso right away. Maybe
Mhm.
about 35% as opposed to 12% for the placebo arm.
Mhm.
But I think overall, I have to say I'm very impressed with osimertinib. In fact, I have patients who
Mhm.
have taken it as long as 15 years to 10 years to 5 years who are still
Wow.
taking it. So with very minimal side. These are all older patients, frail, and it's amazing, that they continue to take it, I think, without too much side effects.
Right, right. This is a very, very impressive study. I do agree. And yeah, so this is like for EGFR mutations patient. How about if a patients have other mutations? For example, on the Crohn study, which is focused on the ALK rearrangement, could you also explain to us what is the Crohn studies about? And then do you think any significant impact on the practice?
Yeah, sure. I think, in the Crown study, again, they focused on non-small cell lung cancer.
Mhm,
And here they focused on what we call as a ALK mutation.
mhm,
So generally speaking, in stage 4 patients, if you
mhm.
check next generation sequencing studies, you can get anywhere from 2 to 7% of the patients who are ALK positive.
Okay,
And a typical lifespan of these patients is probably about 7 years.
okay.
So what they did on this Crown study is that they kind of picked up stage 4 untreated patients,
Mhm,
and then basically about 296 patients on the so-called the lorlatinib,
mhm,
um, um, and they compared that to crizotinib, the
mhm,
other like a first generation drug, to
mhm.
see how the patients did that. So
Right.
what they noticed was, I believe they've published the report at 2 years, 3 years. Now this one is the 5-year mark, like
Mhm,
60 months. Even
mhm,
at 60 months, the endpoint was so-called progression-free survival that's still not reached on the patients who are still taking their lorlatinib.
mhm,
And basically on the placebo arm, the so-called crizotinib arm, it's only 9.1 months.
mhm.
Again, the so-called hazard ratio is 0.19. Very, very,
Mhm.
very impressive.
Right.
So the other interesting thing is the so-called intracranial disease. Again, this also penetrates the blood-brain barrier.
Uh-huh.
So what happened with this study was they had patients with both brain mets versus no brain mets. So
Mhm,
what they noticed was it was very impressive even with patients with brain mets versus no brain mets. Now,
mhm,
the ones who are already in brain mets or they were about to develop brain mets, they kind of whoever was showing progression or whatever it is happened
mhm,
only the first 2 years.
mhm,
After that, it almost kept it quiet. So, which means to say, once the initial ones who are already had the brain mets, whether they got radiation or not, whatever happened with them, then pretty much when the drug kicked in,
uh-huh.
kind of pretty much kept it completely clean, I think. So
Mhm,
this is very impressive, I think. Crizotinib arm, whereas they had at 16.4 months, they
mhm,
probably had basically some sort of a brain met. And the other
mhm.
impressive thing about this study was they used next generation sequencing studies by using circulating cell-free DNA, the so-called garden assay,
Uh-huh.
and they checked it at baseline. They
Mhm,
also checked it later on, periodically. What they noticed was, see, doesn't matter what treatment we give, you have
uh-huh.
to remember cancer cells also like to bypass, like
Right.
they develop the so-called bypass mechanism to become
Mhm,
resistant to that. It's like, you have to look at cancer cells like any other living creature.
right.
The living creature will do everything to survive. That's
Right.
basically how it does. So what we
Uh-huh.
noticed was when they did the circulating tumor DNA for resistance,
Mhm,
because this was so effective, and it can not only took care of the patients with the classical ALK mutation, the so-called
mhm,
1A. It
mhm,
also affected the ones with so-called variant of ALK1,
mhm.
31A, and also it helped patients with so-called P53 ones. So,
Right.
which means to say, it kind of really affected all the mutations, which kind of the so-called co-mutations which came with that, and kept it suppressed.
Uh-huh.
Whereas the crizotinib arm, they were able to develop resistance.
Right.
So, if you have a drug which can keep the resistance mechanism in check for as long as possible,
Uh-huh.
that's amazing, I think. So the
Right.
next question which comes up is, oh, if the study is 5 years, people may start wondering and scratching their heads, say, how long do you want to give this?
Right.
Because,
Right.
if, as you notice, Melody, in the so-called checkpoint blockade therapy in
Mhm,
stage 4 patients, we give it for 2 years,
Years.
and if they
Right.
continue to remain in remission, we stop it,
Right.
and they continue to do fine.
Right.
So why not this drug? So
Right.
right now, I think, I believe this question was asked in the session, but there is no answer to that. Right
Mm.
now, I think as far as we all know, we
Mhm.
need to continue with this. I think, we cannot stop it. The only problem with this drug is, I mean, obviously it's not an easy drug to take.
Right.
So we have
Durability.
to,
Right.
watch for the so-called side effects, I think,
Right.
So basically, the side effects will be like one is like so-called CNS side effects. I have to mention that
Mhm.
because I have seen patients
Mhm.
where the so-called CNS side effects, which include cognitive ones.
Mhm.
CNS side effects, just to let you know, it's 42% of the patients. The
Wow, that's
cognitive
high.
effect is 28%, mood
Mhm.
changes 21, speech 6,
Mhm.
psychotic episodes 5. So CNS has been a major one.
Mhm.
And the other one is the cardiovascular one. Okay,
Right.
and also the so-called CVA. So there is
Mhm.
increased incidence of thrombosis, cardiovascular. So
Mhm.
the question which comes up for you is, I always kind of, unfortunately, crizotinib also does the same thing too. It's not like
Mhm.
it's special only to this drug.
Right.
So what do we do in a patient who already has cardiovascular, who has a high risk of cardiovascular disease,
Mhm. Mhm.
or high risk of CVA? How do we handle these drugs? That's
Right.
one question you really have to talk to the patient, look at the risk and benefits. And
Mhm.
then the other question is the so-called CNS things. I've seen it at least in a couple of my patients,
Mhm.
especially the cognitive ones. Suppose you have a patient who is a white collar worker, or,
Mhm.
he or she has to perform at a very high level. How does it impact them and all,
Right.
So
Right.
these are the questions, which we have to keep in mind when we sit down and talk to the patients.
Uh-huh.
And again, you have to use your clinical judgment when to use them, I think, Now,
Right.
the other
Right.
question which comes up in those patients is, should we start off with the other drugs and then add this later on?
Right.
But
Right.
then you lose the chance of suppressing all the mutations, I think. So it's kind of
Mhm.
something you need to have a good discussion with the patients, I think, before we
Right.
start.
Right, right, absolutely. We have to watch out the tolerability as well,
Mhm.
right? So do you usually start with the full dose, 100 milligrams, or do you usually start with the low dose and then titrate it up?
Initially, I think I started with a full dose, and then later on, I realized what I do is I start with the mid-level dose. I
Okay.
mean, there are different ways of doing it. You can start
Right.
off with a full dose if the patient is doing, looks pretty good, the performance
Mhm.
status is good, no other
Mhm.
problems, and then after some time, you can dose reduce it,
Yes,
and
right,
you're not compromising the effectiveness in any way. But
right.
if I see somebody who's frail, old, maybe I'll start with a mid-level dose and then
Mhm.
see whether I can work my way up or down, I think.
Yeah, that's right. That's right. Yeah. Thank you very much for summarize the important trial for us. And another question is for another trial. We know one of the risk factor for developing lung cancer is the smoking history, especially for the small cell lung cancer you just mentioned. And this year, ASCO, Adriatic trial received a standing ovation during its presentation at the plenary session. Could you tell us more about this trial and were the results truly groundbreaking?
Yeah. So the Adriatic trial focused on small cell lung cancer, different than
Mhm.
the other two trials.
Mhm.
And in the small cell, remember we talked about so-called in small cell, we classify them into so-called limited disease and extensive disease.
Right.
When I say limited disease means the disease is confined only to the lungs
Mhm.
or the lymph nodes. I mean, everything, but the definition of it is, this is an old classification which has stood the test of time.
Mhm.
In the olden days, when the patient got the radiation therapy, does it cover the radiation port or not? That's how the definition came as a limited disease. Okay,
Right.
so limited disease doesn't matter the stage 3A, B, C, whatever it is. we still call it as a limited disease because the radiation can cover those regions. And then anything beyond that is so-called extensive disease. So here they focused on only on the limited disease. So just to give you the background, small cell lung cancer has been a challenge in medical oncology. It's one of the fastest growing tumors, and left untreated, you can lose the patients very quickly in weeks or a couple of months. And so and then just to let you know, that's why chemotherapy is effective, radiation therapy is also effective, but the problem is they come back again. Okay, so remember what we talked about before, the survival of these patients. So and the treatment, the so-called standard of care, is still the same for the last 40 years, chemoradiation therapy. So we didn't really have much to offer the patients, despite all the developments in other type of lung cancer and any other malignancies. And for the first time, I think, thankfully, we're seeing some silver lining in the horizon. So basically, in the so-called Adriatic trial, what they did was they basically, after finishing the so-called standard of care treatment, what they did was they kind of gave the patients checkpoint blockade therapy with the Imfinzi or the durvalumab to 264 patients, and the other arm was placebo patients.
Okay.
But this is still a preliminary one. They really classify that into three classes. One group was they used the so-called just the Imfinzi alone after treatment. In the second arm, they used not only Imfinzi, but also the second drug called the Imjudo, which is a CTLA-4 block. That's also immunotherapy. They're trying to see whether 1-2 punch immunotherapy is better than one alone. And the third arm was the placebo. Right now, we have some information only on the so-called checkpoint blockade therapy or the Imfinzi or the durvalumab when compared to placebo, because there was such a significant improvement. The committee decided to release it, I think. So that's basically what it is. So we'll have to wait until the whole study comes out whether 1-2 punch is better than one punch. Okay. So right now, what we know is, remember what we talked about before. I think, in patients with even the limited disease, the survival is only about 15 to 20%. This improved the survival by almost 22 months. Okay. That's huge. The overall survival was 55.9 months versus 33 months on the other arm. So, and that translated into almost close to 22 months. And then, the side effects, it's not, people are very familiar about giving the so-called checkpoint blockade therapy. Pretty much there's no oncologist who's not giving checkpoint blockade therapy. Typical side effects, we watch out for, thyroid issues, pneumonitis, we just have to keep an eye on them. And I think, overall, patients tolerate very, very well. And the other thing I just want to add, moving away from the study, I think we're making inroads in small cell lung cancer. And we are not just this one, we're finding more targets. One is the so-called, we're trying to use the other form of immunotherapy, so like the bispecific T-cell therapies, using a target on the small cell lung cancer, DLL3. Currently, that's still in phase 1, phase 2 trials. I believe the FDA approved for extensive stage small cell lung cancers, antibody directed, radioligand therapy. And then, the other forms of immunotherapies also are coming into play, I think. So thankfully, we're making inroads into small cell lung cancer too. Eventually, I'm sure they'll make their way into limited stage small cell lung cancer too.
Well, this is awesome. This is great news for our patients. And I just want to confirm, is this immune checkpoint inhibitor we use as this consolidations only for 2 years, correct?
Yes.
Okay. All right. Well, amazing. We got a lot of information, and thank you so much, Dr. Rajendra. And thank you for sharing your expertise with us today, and your insights have been incredibly valuable. And we're truly grateful for your time and knowledge. And I also like to thank our audience for listening to today's episode. And this podcast is brought to you by Pharmacy Operations at the American Oncology Network. You can listen to all the podcast recording on our website at www.aoncology.com. And we hope you enjoyed this episode and look forward to seeing you at the next one. Thank you very much. Thank you.